Thank you for hitting play, and welcome to the series we're calling Data Pioneers. We're bringing together the brightest minds in the healthcare industry, supporting the transition to value-based care. We'll be highlighting the best practices, tools, lessons, and advice with a focus on data and analytics. I'm your host, Rich Waller from WellStack, and we're very excited to have you join us today. Katherine, welcome to Data Pioneers. We're really excited to have you on the episode today.
Thanks for having me. Excited to be here.
Yeah. So, maybe just to kick it off, it'd be really helpful for you to just kind of really orient us. It'd be great around your expertise, sort of like how you got here, a little bit about your background, and really kind of getting you, prepared and ready and passionate about, this career journey that you have, and especially around the value-based care aspect of things.
Absolutely. Well, I'm a nurse practitioner by training. I started my career in cardiology as a nurse in the cath lab and cardiac rehab and ICU, and then moved into a role as a cardiology nurse practitioner in inpatient and outpatient world. And from there, I moved into Optum, spent 10 years there in complex care models and learned a lot about value-based care, how to manage a Medicare Advantage patient, how to really understand the clinically complex patient and how to get that patient through a difficult period and really care manage in that way. Also learned a lot about quality, what quality metrics meant, how they work at Medicare Advantage, and how we can improve quality through quality improvement processes. During that time, I was at Optum. I got my doctorate at Vanderbilt and decided to move into a academic role. So I spent a couple years at Georgia State University. I started a doctoral program there, and again, spent a lot of time on clinical quality in that academic role. After that, I went to United Healthcare. I moved into the health plan world, spent 5 years there as the chief nursing officer for Retiree Solutions, where I learned about how to manage populations in a health plan, what clinical programs look like, and how we could provide the best possible clinical experience for a member, along with the provider teams. And then all that experience kind of led me to where I am today, which is Novocardia. So I've been here about 3 years. And in this world, I have spent my time building what is value-based care in cardiology. So I've defined what does the clinical model look like, what does the world of cardiology look like, and how do we take that knowledge and create transformative cardiology care that provides better outcomes for patients at a lower cost.
Wow, certainly. I mean, that experience is amazing, and also I think probably necessary to spend time on all sides of the aisle, if you will, in terms of being able to really understand how that all comes together. I think when we think about the kind of broader transition to value-based care throughout the country, that's actually the reason we sort of started this series, was to really get a collective mind share of those passionate and really also in the trenches every day in this area. So from at the highest level, how do you see Novocardia really contributing to this systemic transformation? I mean, because it's such a monumental shift that we have as a country. So maybe some thoughts specifically about kind of the Novocardia aspect of it, but then also your thoughts on our sort of nationwide transformation and, how you think things are going and how we can be, maybe, continuing to accelerate that path.
Right. So, right. I mean, we've all heard CMS wants everyone in a value-based care arrangement by 2030, which is just 5 short years away. And needless to say, there's a whole lot of work to do in order to achieve that goal. At Novocardia, we really wake up every day and live and breathe this. How do we create these care models that work, and how do we get them deployed into our practices and other practices that make it useful, meaningful, and create a better experience? So in order to do that, you first have to really start with a credible model that makes sense to clinicians. Doctors don't want to do things that don't seem logical and are not going to create the best experience for their patients, and frankly, that are not going to be too disruptive for the provider experience as well. So as we think about value-based care, you really have to start with how are you going to do it, and what's the clinical model, and how is that going to work? And then really selling that in terms of how is it going to work at a contract, and all those things have to tick and tie together very carefully and have to be well thought out, along with understanding the data and where the opportunities lie to create savings. So we've spent a lot of time looking at that and identifying where those opportunities are and how we can impact them meaningfully.
Katherine, I'd love to hear about the importance of measuring impact on these programs that you're proposing to potential partners and standing up for existing clients. How does that play a role with that credibility in the model that you're looking for?
I think measuring impact is critical. And without a plan to measure, you're never going to be successful in value-based care. So you have to know as you start out, what are you going to measure? Why are you going to measure it? How does it matter? And then having a plan in not only how you're going to do that work, but also how you're going to share that back with the clinicians providing the care, the frontline staff providing the care, the administrative staff that are involved in this work, as well as whatever partner you're working with in your value-based care arrangement. And we all know that if you didn't document it, it didn't happen. It's sort of the same way with quality. If you didn't measure it, it didn't happen, right? So without a measurement plan, then you really may as well not be doing the work, honestly, because you have to have a way to capture it. And you can't improve if you don't know where your gaps are. So if you're not measuring things, you're not defining gaps, you're really just sort of moving through your day in ways that are not as prescriptive or meaningful. So we really set up all of our processes from the outset and think about what do we want to measure and why we're measuring it so that it helps us achieve whatever we're looking to do, whether that's getting patients on a certain medication, whether it's avoidable utilization, whether it's making sure that we have patients who have access to appointments, right? So there's a lot of different things we think about, and measurement is critical in order to be successful.
And, we love to get into the weeds on the actual kind of data element of things. Tell us about some of those key data sets, and then, any advice you have for other leaders out there that are looking to kind of wrangle these complex data environments into, a solid platform for measurement.
So we really want to have full claims data in order to be most successful, including Part D, having the medications and the prescribing data as well. And so that's certainly a start. And then you need a medical economics team that can help you understand that data, that can help you bucket the data into where is the largest area of spend, how is that spend impactable. Not all spend is impactable, right? So I'll give you an example. There's patients who have atrial fibrillation and they need blood thinners to avoid a stroke. And some of those medications are very expensive, and we can't stop those medicines, right? People need them so they don't have a stroke. That's not necessarily impactable spend. What is impactable are areas like if you look at heart failure and you have a lot of people going in and out of the hospital 3 or 4 times a year because of their heart failure exacerbating. Those are things we can impact by having better care in the outpatient setting, better management of medications. And through data, we can identify who those people are. We can identify where they're going. We can identify their patterns. And then we can create a process to intervene and provide that care upstream instead of that downstream utilization of going into the hospital or the ER over and over again. So again, it's really having that team that can understand that. And then once you have that team and you understand where that data is, then you have to find a way to surface that. So depending on how deep you are into a relationship or a value-based care arrangement is how deep you want to get into that data and how deep you want to surface that to providers. So you really need to understand what the goals are before you start putting things in front of clinicians. Frontline staff do not like noise. They have a lot of noise in their day. So there's a lot of alert fatigue in the day. So as you think about the data and where you want it to go, it needs to be very impactful. It needs to be whatever is critical to solving your problem without any additional, without the fluff, essentially. So, and you've got to choose your tools. So I think one of the things we talk about a lot is rules before tools. What are you trying to achieve before you choose the tool? If you go and implement a tool without knowing exactly what you want to do with it, you've wasted your time, your dollars, and everyone else's, and you're not going to achieve your outcome. So that's another critical piece we look at a lot is before we embark on a tool, what exactly do we want that to look like? How do we want to use that with our providers? And how will it create the outcomes we're looking to achieve?
That's really, I mean, I think that's just, it's really a great way to think about not only team formation, but some of those priority items that are so critical. Are you predominantly operating within a pretty disparate claims and EHR environment for your data sets, or is it relatively uniform? Like, tell us about some of those challenges that, or opportunities that you have.
I wish it was uniform. It would make my life a lot easier. It is not. And I think that's a lot of people's reality. Things are never uniform. All healthcare is local, and that also goes for oftentimes the digital solutions. They can be very local as well, whether that's the EHR or the phone system or the practice management system. So what we do is we do understand that's a reality that we live in, and we are able to take that data, bring it into our enterprise data warehouse, and collect that data, and then surface that up through some of our population health tools, and as well as bringing it back to our practices through either those pop health tools, through scorecards, or through just one-on-one conversations with our providers as well. It does take a lot of work and commitment when you are trying to ingest data from a lot of disparate places. That's a big undertaking, and I think any organization that wants to really be successful in value-based care needs to be ready for that. They need to understand that there has to be an investment in the infrastructure around the data, how it will be ingested, and ensuring that there's processes to make sure that data are valid. We all struggle with data integrity, so that's having those checks and balances around the data is also important.
That's amazing. Lauren, why don't you jump in?
I'd love to hear, and on the data front, Katherine, what the focus has been or the conversation has been in the cardiac care community around AI, and how some of those models can help enhance workflows or get more refined insight at the point of care. What has that conversation looked like, and where is the cardio care industry headed?
I think like a lot of places, those conversations are still early, and they're also very exciting. There are huge opportunities with AI to help us, particularly in the care management world, where to the earlier conversation about having a lot of disparate data in a lot of different places, those AI rules and engines that can bring that into one platform, or at least surface everything into one place for a clinician, is really going to, I think, decrease a lot of the administrative burden and create more time in the day for everyone. So I think that's one very clear place. Particularly also, we think about this as well in the hospital system, right? So there's a lot of cardiology work happening in the hospital or the ambulatory surgery center that then gets transitioned back to the outpatient setting. So that's another clear place where rules-based work and AI can surface the next best recommendation, ensure that all the checklists are getting checked off for that patient, so that when they do get discharged, they're getting all the pieces they need on the back end. And it's not relying on necessarily someone to fill out a piece of paper or a card. It really all happens in the background and only surfaces the thing to that provider that they need in that moment, right? So, we've all had a checklist in front of us of 75 things that we have to do before we discharge this patient. Well, we may have already done 30 of them, right? So if AI can help just surface to us what we actually need to do in that moment, it really decreases the noise and improves the experience for the provider as well.
Yeah, absolutely. I think I would agree the conversations with AI are very early, but I think that in places like cardiac care, where there's such high cost and such high risk associated with those outcomes, it will eventually play a pivotal role as we normalize its use and adoption out in the market.
I agree. I think additionally, it'll help us more and more with risk stratification, because that's a place where as we look at our value-based care models and we get our claims, we risk stratify our populations, find those people who are the sickest of the sick, outreach to them quickly, and really helps us to create that prioritization. I think that will become more and more sophisticated as AI becomes more and more sophisticated in our work.
And Katherine, you have a number of pretty innovative care models. Specifically, we had talked about the tech-enabled heart failure program that combines sort of some of that remote patient monitoring with telehealth and some other cool technology features. And maybe let's jump into a little bit of that, and because I think that'd be cool to feature.
Sure. I'm really proud of this program. It's something that we developed in our very early days in Novocardia. It does work in fee-for-service and value-based care environments, and that was a critical piece for us, as we wanted to make sure that everything we didn't require a value-based care contract. There are things that we can do differently in value-based care that the payment model allows us a lot of flexibility around, but the overall tenets of the program can still be deployed in either model. The way our program works is we do provide a health coach, and they provide a lot of the education, and that's all via telehealth. We also provide remote patient monitoring tools, blood pressure cuffs and scales in the home. And then there are nurse practitioner and physician visits on top of that. We really focus on a very structured program to ensure that patients get the education that they need throughout the program. They know how to self-manage. And then at the end of the program, they can be discharged and use our teams only as needed and not necessarily have to come in all the time or need that crutch, right? The telehealth was specifically designed to make it more accessible. And we also provide, through our remote patient monitoring tools, not just the blood pressure cuff and scale, but also a device where the telehealth visits can happen through that device. We understand that that can be a major barrier for patients, is having a smartphone, having a tablet, having a computer, and we wanted to eliminate that. So we provide patients a device that they can have visits through, either via video, via audio. They can communicate with the care team via text through that device as well. And it really helps to break down a lot of those barriers that we often see.
You mentioned an interesting context about, and I think it's something that a lot of organizations are struggling for, and something we're really passionate about trying to help our clients at WellStack achieve, is that kind of operating within both the fee-for-service and value-based care environments, right? And we see a lot of folks, I think, maybe, I don't know if it's struggling, but just like it's a unique time where you're kind of working in, still on a lot of the fee-for-service chassis, if you will, of, everything that goes into, the core processes. And so, what have you done at Novocardia to kind of help streamline operating, again, in both of those environments, and, maybe some advice, for those out there that are also struggling with that, or looking for solutions to kind of bridge those gaps?
When we designed our care model, we looked at the evidence, we looked at the data, and we determined where can we make the most impact in a cardiology practice, and how can we improve care the most in a cardiology population. And when we did that, we thought about this not just from the lens of value-based care. We also thought about aligning incentives for providers. So it is not possible to create a clinical model with incentives that don't incentivize the provider. So disincentivized providers are going to never engage in your model. It has to be very thoughtfully designed in that way. So it starts with, where's the opportunity? How are we going to get there? How are we going to make sure that providers are incentivized, whether it's fee-for-service or value-based care? And how are we going to provide the highest quality experience for patients? And we were able to do that in a lot of ways. There's some very obvious ways. Transitions of care is an easy example. Transitions of care works very well in fee-for-service. It is a highly reimbursed service. It is meaningful for patients. It ensures the best outcomes, and it avoids rehospitalizations. And frankly, it creates a better experience for patients. They're often very confused when they get out of the hospital. They have 1,000 things coming at them. And having somebody that will take the time to sit down, review everything that happened, make sure their medications are correct, go through all those bottles with them, those are things that really work for patients, whether it's fee-for-service or value-based care. So that was kind of an easy, low-hanging fruit. Another is what we call Cardiology Connect, and that's the ability to get patients into our office quickly, same day, next day. That's, again, a better patient experience. It keeps them out of the hospital. It gets them into our offices with the doctor that they know well. And it helps the doctors to stay really connected to that person and provide the best quality care. So those are just a couple of examples, but it's really thinking through the workflows, the incentives, and ensuring that when you make those decisions about your care model, that they just make sense for everyone involved.
Absolutely. And Lauren, I'll put you on the spot here. I think that, I'd love to, from an analytics perspective, you have some really, kind of cool thoughts. So tell us about, kind of how you think about, helping organizations, again, from enabling data
Sure.
analytics, as they kind of move from that, core fee for service world up the value-based care maturity curve.
Yeah, and I think, Katherine, I'd love to know your thoughts on this too. Assuming that we have access to the disparate data and that we have longitudinal patient records to look at and use, those things are in place. As you move more from fee for service to, full risk models, there's a lot of need, even in the in between, to understand total cost of care and starting to manage your total cost of care. And, you've already mentioned unnecessary utilization and medication management. I think that in the analytics space, it can be complicated sometimes to make sure that you're providing the right level of insights at the right level of altitude for your audience members. And I'm sure that in cardiac care, you probably run into similar issues where the directors of these programs need very different insights than the people who are running them day to day. Could you talk a little bit about your experience in having to set up that framework of analytics to actually drive the operations end to end?
Yeah, so we start with our Medicon team and we think about what do we want to measure and what's going to be most meaningful for clinical program outcomes and how that will really drive change. So I think that's the piece to start with. And then what are the measures that go into that we're going to look at day in and day out that are actionable? We don't put anything in front of our clinical teams that they can't act on. It's just not useful for them. And we then, as we move through this world, we look at are these actions really making a difference? Are we creating an impact? If we call somebody in 2 days, are they really picking up the phone? And if they're not, what are we doing wrong, right? So it's using those analytics insights to make those next clinical decisions is very important as well. You also have to involve the providers in these conversations as you set this up. So if I start saying, I think this is important for someone to know, then, but they don't, then I might as well not tell them. So that's maybe where I, as a director, would look at that, but I'm not going to put that in front of a clinician. For example, if someone has, their PMPM spend is really meaningful for me as someone leading a program. It is not meaningful for a doctor seeing patients day in and day out, right? So those are the types of things where there's differences, and I want to make sure that I can put in front of the doctor, though, that this person was in the hospital 3 days ago and they have had 6 hospitalizations in the past year, and they really need a lot of help. And these are some of our recommendations and how to ensure that they don't go back in the hospital. So those are pieces how we can think differently. Additionally, when you start a new program, especially total cost of care, the total is in the word, right? You can look at the whole world of cost. So you have to do a stepwise approach. If you start with giving them everything under the sun to manage, they'll manage nothing. So we get very prescriptive on, these are the 2 things I need you to do right now. And other than that, don't think about anything else. Just do these 2 things and let's do them well and let's be successful. And then we can start adding the next thing. So using the data to ensure that we are meeting the metrics, that we are successful in those first early pilots or those first early programs that we're deploying. And then once the data says, yes, you're doing great, once the patient experience and the provider experience are going well, we would then begin to look at the next level and start to add on what we have next lined up in the product roadmap.
That makes total sense to set it up that way. And I actually have a companion question to that, which is around benchmarking. So when you're setting up these programs and as an operator, who's in charge of, we'll say the primary outcomes and profit of a program like this, so it's sustainable, how are you going about establishing benchmarks? And then how do you communicate that to the operators who need to know, here's what we need to get to this year, and here's how we're going to get here?
So we establish benchmarks typically through historical spend and looking at trend. So, and that generally requires a claims dump to know exactly what this population has been trending at and how we're going to bend that trend in our programs. And then through our clinical programs, we define exactly how much of that spend we think we can impact. And then we look at exactly how much we need to engage and exactly what we need to do. And really, we focus our clinical teams and our clinical operators around achieving those program goals that we know that we've defined through our benchmarking process and our med-econ teams as what will create success. So we have to know exactly how our programs will impact the benchmark before we can ensure, before we launch something, right? So that's all part of that opportunity analysis as we look at this. And then what we put in front of the clinical team is then actionable based upon exactly where they need to penetrate the population.
We've talked a lot about these. I think we've touched on it in a few different dimensions because, we talk to quite a few organizations that, are doing, value-based care within, primary care and some Medicare Advantage and are really, looking and kind of excited to move into specialty areas, right? Like cardio and ortho and other areas that they're, kind of targeting, but they're often struggling with just kind of the data ecosystem to get comfortable with, being able to get their arms around risk and things like that. Any other insights for those types of organizations that are looking to move toward, to taking risk in some of their specialties?
I think you first have to understand what is the world of your specialty. We spend a lot of time defining what is cardiology. That's not as straightforward as you might think, and I think that applies in other specialties as well. So that's a clear place to start is defining your scope. And then as you look at that scope, are you going to be able to impact that? And how will you do that? And what are your providers willing to do in order to impact that work? So I can create the most beautiful clinical model in the world, and if no one's going to do it, it doesn't matter. It's starting with the people as you create this work who are on the front lines, who are going to use the tools needed, and bringing them into that process as well in order to be successful. For example, when we launch any new tools, we bring our doctors in to the vetting process. We bring our frontline clinicians in. We bring our administrators in. We have them look at everything and go through that process alongside our teams. Because really, these end users are going to be very important, and it also creates buy-in. And as you launch these new programs and new contracts as well.
Let's talk about sort of the future. I mean, what are you excited about, or what do you see, as opportunity, both from kind of a industry and business perspective, but also from a technology and innovation perspective?
I'm super bullish on the future. I'm really excited. I think we have so much opportunity. There's so much low-hanging fruit. It is really challenging to be a patient in this country, and we can all wake up every day and make that a better experience for every patient that comes through our doors in the healthcare system. And there are many, many technology tools that can help not just the patient experience, but also the provider experience. AI, I think, we are on the just baby step of the very, very beginning of what we can do. I think there's going to be an explosion of opportunities in improving workflows and creating actionable data for providers very quickly and giving patients a better experience. Things that are super noisy for everyone, like prior authorization, inability to get the medications you need timely, getting hospital records, payers and providers interoperability and talking to one another. I think we have very clear opportunities to make huge differences in those places, either with AI or with other, just clear workflow improvements as we continue to work together more carefully.
Yeah, I think that there's, I mean, the other areas that are interesting to me, I think especially in cardiac, what we're seeing with sort of the continued development of digital twin technology and things like that, both from a clinical perspective, but then also from a process perspective, to be able to, more quickly and cost effectively model, both kind of the biology side of things as well as like how interventions affect those outcomes. So I think there's just so many exciting things moving very, very quickly that we'll start to see integrated pretty quickly into a lot of these both clinical and operational workflows.
I agree. There's really amazing things happening in terms of diagnostics and cardiology, and it's very exciting to see, not just in the office, but also the ability to have more diagnostics in the home and monitoring tools in the home that help patients to be monitored in a more comfortable environment and get that data back to the providers quickly. And it just creates an easier experience, and as well as just much more high functioning information.
Let's talk about the home a little bit. Are you guys how much of what the care and the program um, that you all focus on is in the home versus kind of in clinical settings?
Home-based care is another place that I think there's a lot of room for innovation. It is extremely challenging to be efficient in providing home-based visits because of windshield time. And also, we're in a provider shortage, and finding the right people who can go do these visits in homes is becoming increasingly challenging. So we have chosen to focus on putting tools in the home so that we can interact with those patients in the home. Part of the reason, for example, that we provide the phone is because when we want to understand what a patient's pantry looks like, we can have that person walk into their kitchen and our health coach can look at their refrigerator or look at their pantry. We can have them show us the medication bottles sitting on their counter. So it does provide an insight into the home without necessarily having to have that person driving around all day.
Absolutely, that's high, seems highly efficient and really really interesting on kind of the kind of the surrounding aspects of what could be affecting their health. That's really cool.
Katherine, I'd love to hear how patients are responding to having this technology in their home and what their attitude has been towards it.
Most of them love it. It's been very easy for them. The tools we select, I have been very thoughtful in assessing their capabilities in a geriatric population. Things with big print, big buttons, easy to understand. Our scales and blood pressure cuffs talk to the patients, so if they can't read, they hear their blood pressure that day or their weight that day, so they don't necessarily have to see it. So those things have all been helpful for patients to make that accessible. And they really have they grow very attached to our health coaches. They love those video visits. They get very excited for the time together. And they not only have found that they're able to improve their health, but they also have a new sense of their self-management abilities. And that's something that we've learned through surveys that I think is pretty exciting, that through these digital tools and having this help for them in a very prescriptive and meaningful way, that they really feel more empowered at the end of the program. And we're really proud of that and the opportunity to be able to serve that population.
It's fantastic to hear.
Yeah. Katherine, this has been really, really insightful. And some of the stuff that you all are doing is just so innovative and really just exciting to see so much progress in this area. Any final thoughts for healthcare leaders that are looking to kind of move towards some of these more innovative programs that you all are rolling out?
I would say don't be afraid to jump in and do it. Make your plan, be thoughtful, take the time to do it and do it well, and know that it's really going to make a difference for people. And don't let the unknown scare you from really making true, powerful, meaningful change for patients and providers.
Amazing. So Katherine and Lauren too, is there anything that I didn't ask yet that you think we should add that, and obviously we can put it back in the episode wherever. Anything you were wanting to kind of highlight, or anything, at Novocardia that you wanted to feature?
I think I covered most of what I had. Lauren, did you have any other items?
No, nothing on the big checklist, maybe a little checklist, but I think this has been really fantastic.
I actually think this is going to be awesome because like it's tight there. It's really dense with really great insights and featuring some of your innovations. So yeah, I mean, this has been fantastic. Katherine, thank you so much again for joining us and for spending the time. It's so exciting to hear all the great things that you're doing, and we'll hope that you can join us again, maybe as we move forward, because I just would love to stay in touch with everything that you all are rolling out and continue to learn more.
Thanks. We would love that. And this has been a lot of fun for me. I appreciate you guys featuring this.
Excellent. Well, thank you.
All right. Have a
Thank
good
you.
one.